Recording in progress.
So I've started recording, Louise, okay?
Yeah, that's fine.
Yeah. I can't see who's joined. Oh, I've got 26 now, okay. I think it's 1:30, so should we make a start? Good afternoon, everybody. Welcome to this CIPFA webinar on integrating care, making it count. I'm Andy Burns and I'm an Associate Director at CIPFA, and I've had the privilege and pleasure of chairing the reference group that CIPFA established, which oversaw the publication that CIPFA launched in December last year on integrating care, policy, principles and practice for places. Before I ask my colleague, Dr. Eleanor Roy, who was the prime author of that document, to set the scene for us, just a few words about the logistics and housekeeping for this afternoon's webinar. Firstly, it's being recorded and will be available after the event on CIPFA's YouTube channel. The PowerPoint slides will also be shared after the event. We want to make it an interactive event, so please do ask questions via the Q&A button, which you'll find at the bottom of your Zoom screen. There'll be you can ask questions throughout the event. You haven't got to wait for defined periods, but we'll be picking up the questions and hopefully answering them at the end of each individual session. We're also in the final session at the end of the third of our themes at round about 5 to 4. Hopefully we'll have time to answer as many questions as you're able to ask. I spent more than 30 years in senior finance roles in local government, working in partnership with the NHS, and in various places we've delivered some really good things in the sort of partnership working, integrated care sort of space, but nothing like the full potential that integrating care could provide to improve the health and well-being of the populations we serve. The opportunity that's arisen by putting integrated care systems on a statutory footing, which was only July 2022, seems like a lot longer ago than that, but it gives us a real opportunity for a step change and to build on the fantastic joint working, particularly during the COVID pandemic. But integrating care is not a silver bullet, and there are many significant issues, challenges and questions still remain. Now at CIPFA, our business and purpose is about promoting good public financial management and good governance, with a focus on outcomes, accountability and financial frameworks, which are critical elements in ensuring effective collaboration across organisations which have different systems and cultures. So the CIPFA publication on integrating care aims to be helpful to both policymakers in NHS England and the Department of Health and Social Care, but also importantly for finance practitioners who are charged with trying to make this work on the ground. Now, to give greater focus on the health and well-being of the populations we serve, not just on the illness and care needs of patients and the service users. Now, of course, that's easier said than done, especially when the longer-term aspirations of integrating care are being crowded out and by the significant here and now pressures that are being faced in both the NHS and local government, those councils responsible for social care, whether that's from elective backlogs, ambulance response times, access to GPs, social care reforms and charging changes, workforce shortages, inflationary pressures. There's a temptation to focus on firefighting in the here and now, whereas integrating care is actually a longer term challenge. But to deliver better public financial management for the tens of billions of pounds that taxpayers are investing in health and care, I guess the challenge, I guess the plea is, how do we get integrated care from your radar, where I guess it is in your organisations, onto your agenda, so you're doing something about it and planning for it today. It may not be your most urgent priority, but our contention it will be one of your most important priorities. So this afternoon we're hopefully helpful for you in that regard. So we've got 3 sessions with some expert practitioners who were drawn from the reference group who put the publication together. We'll take a break at 3:05 for 10 minutes or so for a comfort break. So just final reminder to please use the Q&A buttons during the course of the webinar at any points, and so we'll pick up those questions at the end of each slot and at the very end. So that's it from me for now. I look forward to hearing from the presenters and also hearing your questions, and I'll try and put those to the panelists as we go through. But it gives me great pleasure to introduce Dr. Eleanor Roy, who's the Health and Social Care Policy Manager at CIPFA, to set the scene about what's gone on and what's going on currently in the system. So Ellie, over to you.
Thanks for that, Andy, and thanks all for joining us this afternoon. As Andy said, in December last year, we put out a report integrating care, policy, principles and practice for places. I'm never sure if I get them all in the right order, but it aimed to do a number of things. It looked at the wider landscape across health and care and tried to set the scene, but also focused in on arrangements at place level that had been set out in the white paper at the beginning of 2022. So looking at arrangements in place-based partnerships around outcomes, finance and accountability. So just in terms of that wider landscape bit, it's been 4 months since we published the report, and it feels like there's been an awful lot of water under the bridge since then, which I can't really do justice to in 5 minutes I've got it. But what I will try and do is give a brief summary to give some context to where we are now. And I come with a health warning, and none of this is particularly cheerful, so I do apologise. Over winter, we've seen an escalation of the long existing pressures across the health and care system. We've seen numerous funding announcements in response to that. However, most of them have been quite short-term and reactive. So, for example, to address issues in urgent and emergency care and in particular delayed discharge. Disappointingly for the latter, we've seen a lot of focus on social care as being a pressure point rather than a more integrated view, including the wider primary and community care as well. At the same time, in recent weeks, we've seen plans to reduce ICB staffing budgets by 30% over the next 2 years. Many NHS capital programmes have largely been put on hold due to escalating costs around the situation with inflation. Obviously, we've seen industrial action, and now we have a potential pay deal on the table for Agenda for Change staff, but a lot of concern as there's been no indication as to how this will be funded and paid for. We still have no long-term workforce plan, although the Chancellor last week was keen to ensure us that it is coming imminently. And we've also seen delays to social care charging reform, and over the last few days, rumours that funding for wider service reforms in social care may be cut or diverted elsewhere. As we rapidly approach the end of the financial year, a number of integrated care boards are still forecasting year-end deficits, and the initial financial plans for the next year are looking even more bleak than they did at the beginning of this financial year. We understand on the bigger picture, we understand that the Hewitt Review, which was charged with looking at oversight and governance arrangements for integrated care systems, even though they're less than a year old, we understand that the initial report went to government last week, although nothing yet has been made public. However, at the level of place, which is where our work focused, many systems now have arrangements in place, pardon the pun, and they are running their place-based partnerships, while others are still thinking about what arrangements to put in train. The white paper at the beginning of 2022 did commit to further guidance around outcomes, accountability and finance at place level. And again, this was what we intended to inform with our publication. To date, that guidance has not yet emerged. So overall, there's been a lot happening, but very few great strides forward. However, what I want to stress is that although it's been 4 months since our report, our key messages in that report still hold. We need to have a longer term view. We need to be able to take a twin track approach to deal with the immediate pressures, those short term reactive responses, but also to enable long-term investment in transformation and prevention that is needed to maintain and keep these services sustainable. And the other important message that I'd like to stress from our work is that not all systems and places are equal. There's significant levels of variation, meaning that any guidance that does come out needs to be flexible to local circumstances and to enable our places and systems to adapt over time as they will continue to evolve. So apologies if my little bit of context hasn't been particularly cheerful or given you much to smile about, but we do have a fantastic panel of speakers this afternoon, all of whom have been involved in the group that led this work, which I owe them a debt of thanks for. And I'm sure that they will have a brighter view from the good work going on in their own areas.
Thanks, Ellie. That's really helpful in terms of setting the scene. Okay, so the first session then has a focus on place, partners and prevention. And we've got 2 speakers in this session. We've got Terry Collier, who's Deputy Chief Exec and Chief Finance Officer at Spelthorne Borough Council in Surrey. And we'll be followed by Lee Outhwaite, who's the Chief Finance Officer at NHS South Yorkshire Integrated Care Board. So we're going to hear from Terry first, and then Lee, and then we'll have a chance to ask them questions. I think one of the key elements of the SIPFA publication, the guidance, is about the important role that sort of district and borough councils play with regard to the health and well-being of the population. Much of the attention is given to councils with social care responsibility, but actually many of the levers for improving health and well-being of populations are held by district and borough councils. So Terry's going to give us a Spelthorne and Surrey perspective on that dimension. So Terry, over to you. Looking forward to your presentation.
Thank you very much, Andrew, and a very useful introduction. So just to introduce myself, I'm Terry Collier, Deputy Chief Executive for Spelthorne Borough Council. So as Andrew says, I will be giving a district or borough perspective in terms of the integrating care agenda. And like other speakers, I've had the privilege of being on the reference group for the Policy Principles Practice for Places document. So if we could move on to the first slide, please, Louise. Like many councils, Spelthorne, of course, has a set of corporate priorities. And the point I want to draw out is actually how typically these priorities actually link into a number of the key determinants which have an impact on the health and well-being of our residents. So in our case, one of our 5 corporate priorities is around delivering affordable housing, and clearly ensuring that all our residents live in a safe, appropriate form of accommodation has a key impact on their health and well-being outcomes. We have a focus on recovery, which is around recovering from the impacts of the pandemic, the economic impacts, and also cost of living challenges. So again, ensuring that all our residents are able to live prosperous lives and making a meaningful contribution through some form of employment, if possible, is another important determinant in terms of people's health and well-being. And then alongside that, we have a focus on environment, and again, this, in our case, because our proximity to Heathrow, a clean air environment is important, but equally providing open spaces where people can go, relax, and be healthy, again, is important. So this just echoes the comments already made in terms of the fact that districts and boroughs do have levers through the policies and services they deliver. So if we could move on to the next slide, please. So I'm not going to dwell very long. You'll probably be pleased in terms of on Spelthorne, but just to put us into context, we are located in the northwest corner of Surrey, very close to Heathrow. Relative to the rest of Surrey, we have higher levels of deprivation, which therefore has impacts on the health and well-being of our residents, and that also then feeds into how we address those impacts. One thing I do want to draw out in terms of Surrey as a whole, as a two-tier part of local government, is that we are a little bit unusual because in Surrey, it's the districts and boroughs who provide independent living services. So we provide day centres for the elderly, Meals on Wheels, community alarms, etc., which is actually a contrast to most other two-tier parts of the country, where usually it's the county councils who have that responsibility. So it does mean in Surrey, the districts and boroughs get a little bit more involved, possibly, in interactions with the integrated care agenda, working with health partners and our county colleagues and social services. So if we can move on to the next slide, please, Louise. Thank you. So as a borough council, we have a number of direct impacts or impacts through our sphere of control or influence, which is the bottom right-hand circle. So you can see some of the services we directly provide which have an impact. So, for example, we are responsible for delivering disabled facilities grants, which helps keep people living independently in their own homes. We provide housing, we provide planning, which helps shape the built environment, which has an impact on people's health and well-being and their access to open spaces, etc. We provide leisure services, and we also provide environmental health, which includes tackling air quality. But alongside that, we work in partnership and collaborate, and by working together, we can all have much more of an impact. So we work with our health partners, voluntary sector partners, the county council, and we work, for example, with voluntary sectors such as the food banks. And by working together on initiatives such as befriending, we can have a real impact on the health and well-being of our residents. So I do want to inject a little bit of optimism after Eleanor's previous slide. But if we can move on to the next slide, please. This is just to give a flavour of the ways we, as just one borough council, do have an impact in terms of helping to ensure that people are living healthy lifestyles. And of course, as has been commented, this is a long-term agenda, because if we can help ensure that people are living as long as possible in an independent and healthy way, that has a significant impact further down the chain in terms of medical interventions, etc. So you can see the range in terms of open spaces, leisure facilities, and some of the independent living services we provide. So it just gives a flavour as what we as a borough council are delivering. So if we can move on to the next slide, please. This is just summarising some of the services of more of an independent living nature we are providing as Spelthorne. And one I'd like to just draw out a little bit is with regard to step-down accommodation, which is a partnership of ourselves and 3 other district and borough councils in the northwest of Surrey, working very closely with the Northwest Surrey Alliance to put in place additional step-down accommodation to help ease people coming out of hospital, being discharged, to ensure they've got the support before they are expected to live independently on on their own, and it has been very positive in terms of the certainly the first few months of this winter, where it has actually eased some of the pressures on our local hospital. So again, it does demonstrate that working together, we can make a positive difference. So if we can move on to the next slide, please. This is just to give a flavour of the point around collaboration, that we have to work together if we're going to make an impact on these very, very challenging issues we as a society are facing. And so this is just a flavour of some of the partners we as a Borough Council are working with across the borough. So we could move on to the next slide, please. I've mentioned leisure a couple of times. One of the things we're very focused on at the moment is delivering a new leisure centre for the borough, which actually will be the world's first full-size wet and dry leisure centre, which meets the energy efficiency passive house standards. But equally important, it's designed to be accessible. So for those with physical disabilities, helping them access the swimming pool, but equally it's designed to be dementia friendly. Because again, we need to ensure and encourage all parts of our community to be engaging in activity which will help them to continue to live healthy and independent lives. So if we can move on to the next slide. Apologies if you can't read this slide very clearly, but what this is touching on is one specific part of the home housing agenda, which is about supporting those who are most vulnerable, i.e. the homeless. And in Spelthorne, we a couple of years ago completed a 31-unit single-person homeless hostel facility, working in partnership with a housing association. And we've also delivered a 20-unit family emergency accommodation scheme. And again, it's about supporting all parts of our population to protect their health and well-being outcomes. If we can move on to the next slide, please. Louise? Yes, thank you. So this slide actually highlights some of the challenges around actually working in partnership across the health sector and the local government sector. So in Spelthorne, we are fortunate enough to have been selected as one of the 6 pioneer so-called Cavell Centre schemes. So this is a scheme where we're trying to bring together primary care, community care, mental health, outreach alongside voluntary and council activities into one facility. And in our case, we're trying to do it on a regeneration site. But one of the practical challenges we've encountered is the fact that local government and health sector work under different financial regimes, including different VAT regimes. So we are consuming quite a lot of work, or effort rather, in terms of engaging with HMRC to try and find a way which doesn't adversely impact on our health colleagues in terms of their exposure to a VAT bill, which of course pushes up the cost. Unfortunately, at the moment, the Cavell Centres are on a national pause in terms of funding, but we are working with colleagues to ensure that we get this back on track. So we are still very much optimistic that this will happen and will make a real difference to our residents in terms of their ability to access services. If we could move on to the next slide, please. So I think it's really important that when councils are responding to the Health and Social Care Act, and that we actually build on what we've already got in place. And as has been commented, we're all starting in different places, we're all at different levels of maturity. But one way of doing this is to build on existing mechanisms around health and wellbeing strategies and oversight boards. So in our instance, we've converted our health and wellbeing board into a Healthy Communities Partnership Board, which effectively is a place board for the borough. And you can see on this slide what its objectives are, and it's around actually making a tangible difference, being lean and efficient, and making things happen. So if we can move on to the next slide, please, Louise. Can we move on to the next slide? Oh, sorry. Sorry. Apologies. We've skipped. That's my fault. but the slide before, you can see the types of members we've got. And as you expect, it's got health, voluntary sector, the county council, etc. And one key objective of the board is to focus on actually how we can create some pooled budgets to actually support and almost experiment with different local initiatives to make things happen again. So move on to the next slide. So yes, so you can see under item 8, the retained pool budget to enable local community-led, and that's really important, needs to be led by the community interventions. And then final slide, and I won't show it now, but on the basis that these slides will be circulated, if you have a look at the link, the video there, you will see quite a useful case study presented by actual people who've benefited from the service around our Step Down initiative, which I referred to earlier. So hopefully that's giving you a little bit of a feel for how we as a Borough Council are trying to make a contribution towards the integrated care agenda. Thank you very much.
Thanks, Terry. That's great. A really wide-ranging, comprehensive exemplification of all that's going on in Spelthorne and Surrey. And I was struck by the range of the partners involved in engaging in the process and the number of specific and different things that are going on. Hopefully that might prompt some questions from colleagues and on the webinar who might be interested in some more of that. But we'll move swiftly on to introduce Lee Outhwaite, who's the Chief Finance Officer of the NHS South Yorkshire Integrated Care Board, who's going to give NHS/ICB perspective on place, partners and prevention. Over to you, Lee.
Thank you, Andrew, and thank you, Terry. It's good to see everybody virtually. I don't know if I like virtually anymore. I'm growing slightly weary of it, but it's good to see you, and it saves us consuming CO2, I guess, doing it through this medium, which is entirely understandable. I really would commend to you the Integrated Care Policy Principles and Practice document for places. It's got some really sensible and intuitive stuff in there about what's happening beyond the Health and Care Act that was passed last summer in 2022, and just how different places, different geographies, different upper tier authorities, different ICBs, different second tier authorities are sort of thinking through differently how we do integrated care around here. And I think it is important to sort of note those differences about how different people are approaching this in different ways based on local geography, local relationships, the nature of the maturity of relationships across health and care. But as somebody who's worked in NHS finance for nearly 30 years now, I do think we need to acknowledge we're slightly differently programmed species, the people that are used to working in the NHS versus the people that are used to working in local government. Not better or worse, just different. And the integrating care document does start to describe some of those differences and explain some of the whys. So I'm going to give you a sort of update from a very much a South Yorkshire and NHS perspective about where are we at. Louise, can you do the miracle of this slide sharing? So you can, and thank you. So first slide is lamentably a bit about me, lest any of that's of interest. So I've been in the NHS for a time now, since 1993, in fact, and I've predominantly worked in NHS provision. So this is my first sort of formal role as the sort of ICB CFO. I'm not quite sure whether or not I'm commissioning services or doing something slightly different, incidentally, in terms of what the Act behoves me to do. So I'm grappling with that at the moment. But I, as well as my association with CIPFA, I'm also quite strongly associated with an outfit called the Healthcare Financial Management Association, which is the sort of association for people in NHS finance, which is UK-wide, not just England. And it's sometimes interesting to compare and contrast what's going on in England compared with Scotland, Wales and Northern Ireland in some of this agenda. Next slide, please. I did think it was worth going back to first principles a bit about what happened in the 2022 Health and Care Act, because I do think that's quite a big change. And it's probably worthwhile bearing in mind when we talk about integration from the perspective of how do we help integrate care and health and well-being services between the NHS and broader stakeholders and partners. There's quite a big job going on in the NHS at the moment to just integrate the way we work within the NHS itself. So I think this is a bit of a, we have been labouring under a sort of internal market structure since about 1989 in the English NHS, and we've still got large elements of that open to competition law. So we can't quite wave a magic wand still and sort of get rid of all that competitive internal market. There's still quite a lot of it hanging on in terms of the standard contract between commissioning the ICBs and my hosted NHS providers and further afield. But what the 2022 Act was meant to do and has done is it's got rid of things called clinical commissioning groups, which were practically membership organisations of general practice, and it's replaced that with integrated care boards, or very much charged with how do you convene a system in a different way. Each of those 42 different systems are conceiving of that role quite differently, but I do think that's quite important just to get into the context for people who don't spend as much time in the NHS as I do, that this is quite a big change for the NHS itself. And I do think sometimes local government colleagues are looking at it as going, well, can't you catch up a bit and sort out your own squabbles and problems and what you're trying to do in there? But there's quite a lot of restructuring work going on in the NHS side of the street before we sort of move into how do we partner better with local government colleagues. I was going to talk about next integrated care partnerships and the strategy we've just written in South Yorkshire. So next slide, please. So each individual ICB is now working with it through and with an integrated care partnership. So that's a much broader set of folk. Previous slide, just for a second. Thank you. That's a much broader set of folk than just local government and NHS colleagues. So the integrated care partnership in South Yorkshire is chaired by the mayor of the overall combined authority that sits above the 4 upper tier authorities, unitary authorities in South Yorkshire. So I have Oliver Coppard, who chairs the Integrated Care Partnership Board, that started to develop a bold programme of how do we work differently across health and care. And there's quite a big commonality between the conversation taking place between the Office of the Combined Authority and the 4 upper tier authorities, and the conversation that's taking place between the ICB and our 4 places. So in South Yorkshire, our 4 places are Sheffield, Rotherham, Doncaster and Barnsley. And largely we're seeing those 4 largest conurbations beginning to describe their integration plan, but through this framework around an overall vision for the ICP about happier, healthier, longer lives, some specific goals about fairer outcomes, those lives, and access to quality health and wellbeing support and care. And what we've started to do is describe some shared outcomes around best start in life for children and young people. We're about to launch the strategy, longer and healthier lives with improved wellbeing for those in greater need, particularly skewed towards health equity, and thinking through what facilitates that through strong and vibrant communities and people with the skills and resources they need to thrive. So next slide, please. So we've turned these into some really bold ambitions around ensuring every child is school ready in South Yorkshire. That is not the case by a long chalk. Sorry, previous slide. Trying to do something really different about focusing on prevention and the early identification of disease, acknowledging absolutely that there's a job of work to do around economic participation and all of that cause of the cause stuff about real upstream intervention, and the social causes of diseases are acknowledged in South Yorkshire. So we've got 2/5 of the population living in the English poorest fifth. So we've got quite an unfair sort of overall South Yorkshire platform for this. And what we're beginning to particularly talk about is how we work across healthcare, voluntary social enterprise sector, carers both paid and unpaid, in a really different way. And we've started to describe joint commitments about how we deliver all this work, which I think is quite important. So how are we really going to evidence in delivering this work a really different approach to collaborative leadership, a really different approach to systemic discrimination, and really trying to move resources around from where they currently are to where they're needed, and where they're needed by the most underrepresented and the stakeholders in the population with the least voice. So this is an enormously ambitious strategy that's trying to correct probably for some of the things we've been doing over the last 10 years about really trying to skew more closely into differences in health outcomes. So each one of the 42 integrated care partnerships has just written a strategy that we're about to publish, which probably in fact doesn't look enormously different to this, but it'll be hugely ambitious about cause of the cause, socially determined disease. And what we're all trying to do in health and care at the moment is buffer that up against an operational and joint forward planning round that's got some quite near-term priorities. So I was going to talk a little bit next about the operational planning round and where we were at with that specifically in the NHS. Next slide, please. The NHS has got 8 key priorities about things it's trying to do for next year, acknowledging that absolutely there's a health inequalities agenda there that we're trying to do something about, which is in the bottom right of this NHS slide. But there's a really understandable NHS flavour to the things we're currently doing through operational planning. So, of course, there's a huge emphasis on urgent emergency care access targets. We're all aware of news headlines around what's happening with A&E waits and category 2 ambulant responses, really working differently around community health services, primary care, elective care, LD&A, cancer, diagnostics, maternity and mental health. But all I wanted to point out to people on the webinar really was, this is quite an NHS-centric slide. So we've got 42 ICPs and ICBs at the moment, issuing forth a strategy which is hugely aspirational, talking about health equalities, when a lot, for understandable reasons, of the NHS priorities at the moment are skewed towards here and now services. So our big challenge in South Yorkshire, to be honest, is how do we connect those things together well? How do we create a connection between upstream intervention, assisting with urgent emergency care? Next slide, please. But in a nutshell, within the NHS at the moment, what we're really grappling with is this whole notion of the current incumbent costs of health and care provision, with what I concede are a lot of inherent inefficiency about care not being delivered in the right way, failure demand, and that by which I mean we are seeing people in the wrong care context too late. That current incumbent cost of provision and all that associated failure demand, plus the new things we need to do for next year around elective recovery and mental health investment, which are good things to do. We're currently looking at large deficits in the NHS side because that current incumbent cost of health and social care provision, with all that associated failure demand plus the new acts, is pretty much universally across 42 ICBs greater than our current allocation for 23-24. So if we're going to get into upstream intervention, partnering differently and getting into the cause of the cause stuff, we're going to have to do something quite radical around the current incumbent costs of health and social care provision and how we reduce that in some way, shape or form. And we're all working on that at the moment within the NHS with broader partners going, how do we really ensure that we've got a better discharge pathway out of hospital without alienating directors of adult social care, because we recognise adult social care does not just do discharge management, they do a lot of other things above and beyond that. But what we're trying to do at the moment absolutely is work through how the devil do we work through that conundrum of we haven't quite got the money to do it as we've always done it. We're probably struggling to generate the headroom of what are the silver bullet interventions that will really get rid of some of that failure demand, live within the allocation, then engage more broadly about upstream intervention. It is a slightly simplistic approach to the current challenge for us in the NHS. And my final slide before hopefully we generated a few questions for Terry and myself is what we're trying to do in South Yorkshire at the moment around our approach to NHS financial planning. It is just to describe our place and organisational allocations as well as they can be so that they're kind of accepted. There's a whole host of scope for explaining why Doncaster perhaps doesn't have quite enough funding, or that particular healthcare organisation has got underlying problems that need supporting. But what we're really, really trying to do is start to compare the 4 place programmes of spend to see if we can see any real and tangible differences between primary care and preventative intervention in one place and what that's beginning to do. in terms of hopefully managing disease in a more upstream and clinically and cost-effective way. We're beginning to describe a programme spend analysis across the 4 places, and really to try and to define ambition about left shift. If we concede that we do see a lot more patients arriving in hospital than they should if we're better at earlier intervention, what does that mean? And how do we define that ambition? And we're trying to do that with our hospital colleagues as broadly as we are with our primary and community and wider partnerships, because we've all got to agree with that approach in order to move the money around. I think the enormous challenge for us at the moment is just around data and analytics and getting into, can we really see where we're delivering suboptimal care in terms of not timely enough, not upstream enough, and what's the consequential impact of that around excess costs of provision, and how do we challenge that? We're trying to overlay 4 quite different looking transformation plans in the 4 places. Sheffield's got a huge priority around frailty and geriatric care. Barnsley has got a huge priority around high cost users and trying to do something quite different about personal health budgets. And we're trying to land that in an NHS that's got probably a slightly even more complex funding mechanism around policies like the Elective Recovery Fund. So we're trying to do this huge piece of work, marrying together operational planning with a hugely ambitious upstream intervention strategy, whilst dealing with the incumbent cost of provision in quite a complex financial planning landscape. So it's unsurprising really that we're struggling to brief as quickly and as well as we might our local government and broader colleagues about how we cope with some of these complexities and land them well. You can take the slide deck down there, and hopefully that's precipitated some questions for Terry and or myself.
Thanks, Lee. Fantastic stuff. Real in-depth analysis of some of the challenges and issues that are being faced. So maybe Terry, if you could switch your camera on as well. We've got a question that's come in about double funding of care packages, which I'll maybe say something about myself in the first instance. Typically, my experience of being involved in arguments about funding or debates about funding is actually, one organisation trying to get another one to pay for it. So double funding is not unique, but maybe untypical. And then the other dimension of this question was about sometimes people using GDPR as an excuse for being unable to share information around providing support to service users or patients. So I don't know whether Terry or Lee, you have any practical examples about how you deal with the, if not double funding, but the who funds it challenges and information sharing challenges in the context of either an ECB or from a district borough council. Terry, in particular, you talked about some of the things you provide directly in Surrey that aren't provided by the county council. Some of the independent living support, for example. It may be this question might be better for some panelists further later on in the session, but I want to give you the chance to say anything about either of those 2 issues, about who pays and how you share information to improve outcomes and join up packages of care for patients or service users. Do you want to have a go first, Lee?
More than happy to, Andy, but happy to bring Terry in as well, because he'll have a different and as good perspective, I'm sure. I am not persuaded. Of course, there are statutory differences between what the NHS has to provide around continuing healthcare and what local government has to provide, and we all acknowledge and note that. However, my claim is in systems that work well on this and on information sharing, what you're really sweating here is not the statutory responsibility difference, it's the relationship difference about, is there a shared agenda about dealing with some of these thorny issues? And we all recognise in reality, where's the absolute boundary between who carries continuing healthcare costs or not is more nuanced than that statutory boundary allows for. So I think the big problem with both information sharing and around the boundary between what the NHS delivers and what local government delivers, it isn't in fact that technical challenge, it's a relationship challenge between the NHS and local government bodies. If we have the NHS trying to lay off costs into the local government sector, and if we have the local government sector trying to lay off costs to the NHS sector, we know full well that is not something that leads to good and optimised integrated care. And I think that's why the report that CIPFA's published does dwell a lot on relationships, the nature of those relationships, there are good reasons why we can do data sharing agreements between local government colleagues and NHS colleagues to really get behind that. I'm sometimes moved to think that's not necessarily an issue of skill. We all know how we can do those things. I think on some days it's an issue of will and really trying to work out how does that help the communities that we serve without getting into an internecine battle about what we can't do or who needs to afford particular things, is a personal perspective. Andy.
Okay, thanks, Lee. Terry?
Yes, I think I completely agree with Lee's comment that relationships are at the heart of this, and having really strong relationships where the partners understand each other and what the partnership collectively is trying to achieve is really, really important. And we have a good example locally in relationship with the North West Surrey. Clearly, data protection is really important, and we need to be careful with our residents' and patients' data. But as has been said, that can be addressed by putting in place appropriate data sharing agreements. And just going slightly off tangent, just a comment about funding, and I'm speaking from a borough perspective. I do sometimes feel that there isn't sufficient recognition at a central government level in terms of the contribution districts and boroughs and other parts of the local government make in terms of long-term preventative agenda, and how that actually potentially helps free up or reduce cost impacts further down the line in terms of more statutory interventions. I just feel that sometimes that's lost in terms of the government's approach to forming the funding for lower tier councils. So I just wanted to make that point. Thank you.
Yeah, thanks. Thanks, Terry. I know there's been a follow-up question from, sorry, there's not a name from the person who asked the question, but the follow-up was about information sharing. Just as a personal experience, a while back I was the so-called Caldicot Guardian when I worked at Warwickshire County Council back in the day, who had the responsibility for trying to ensure the balance between freedom of information and data protection. No patient confidentiality, but sufficient data to do service planning. And actually trying to get a protocol signed up to by the key players was a mechanism we used to try and deal with that knotty issue. Because sometimes people are maybe fearful of getting it wrong. And when they're fearful of getting it wrong, they sometimes can hide behind what they think the law says or what they think the guidance is, and actually being open and transparent about recognizing, yes, that's a real issue, that's a practical question, and here's a safe way in which we can share information, which has the endorsement of the key players in each of the parties to the system. That might be a practical way around it, and from experience I've seen that work. Okay, thank you. Terry, if I may, we do hear sometimes about, in some areas, particularly upper tier councils having limited numbers getting involved in ICBs and IPCs. I just wondered, are you unique in Surrey? In Spelthorne are the Pathfinder and the Forerunner, and actually that's not matched by some of your other district and boroughs. And are you aware from your networks that are you ahead of the game compared with others? What are the barriers that other places are having with regard to getting around these ICB and ICP tables? I think you're on mute, Terry.
Yes, sorry. Thank you. I think in part there's a historical factor because well before I joined Surrey local government, districts and boroughs were already providing the sort of services I outlined earlier in terms of independent living services. So that's across Surrey. So as I said, that does mean we get a little bit more involved in some of the agenda than perhaps would be the case. I think there's only one other part of two-tier England which does it to quite the same extent in terms of the district and boroughs involvement. But having said that, districts and boroughs across the country are getting involved, and of course they need to be involved through their health and wellbeing strategies anyway. And as I said, even if you focus on the normal standard services of districts and borough councils, we all have a really significant impact and therefore a significant contribution towards considering how if we work together with other partners such as the county councils, we can actually make a long-term impact, a positive impact, which is in everyone's interest. So I'm not sure that we can take particular credit for being a pathfinder. I think it's partly just a historical situation. And I know there's plenty of really good practice across Surrey. And as I said, in the Northwest Surrey Alliance, it's not just ourselves. There's 3 other districts and boroughs who are doing some really, really good stuff, particularly, as I said, with regard to the Step Down initiative. Thank you.
Yeah, okay. I guess that's, thank you, Terry. And I guess that's an illustration at the risk of an obvious sort of pun. Not every place is the same place, and people are in different places in terms of their maturity of their relationships. Okay. Lee, you very clearly set out a strategy about sort of shared vision and goals for the sort of South Yorkshire area from an NHS perspective. But tell me where you're at in terms of getting your place-based partnerships and partner organisations bought into that, if you like, on a scale of 0 to 10, where 10 is absolutely humming and singing with you on the same page, and 0 means they're looking the other way. Did you get a sense of where you are and where you're moving to?
I genuinely think it's changing quite rapidly, but it'd be daft for me not to observe it isn't different in the 4 places that I serve. And I think there's some really practical things that help with some of the integration conversation. So, for example, one of our place directors who sits around the ICB board table, and all 4 of our place directors sit around the ICB board table, has a dual role. One as the place director on the NHS side of the street, and is also the director of adult social care in Barnsley. I think there's nothing that demystifies more what's going on in your reciprocal partnership through these structures than finding your way into some shared posts. That's not to say that Doncaster, Rotherham and Sheffield are miles behind, but if you've got somebody around the ICB board table whose day job is also being a director of adult social care, you really very quickly get into, crikey, what is going on in terms of socially determined disease around here, and how are some people really living in terms of some of the cause stuff. To be brutally frank, Andy, if you've got a long-standing NHS career at board level, you can be buffered from some of the harsh reality of the things that you're trying to correct for in terms of socially determined disease. So I do think there's something really strong and powerful, not just about the partnership working model working well, but it working well enough to promote some joint appointments, because to be brutally frank, you need to understand these varied perspectives in the health and care system to try and face into them in quite a different way.
Yeah, okay, thanks, Lee. I guess one final one at this stage then, and we'll come back to some others later, I guess for both Terry and Lee, and that's about shifting activity upstream and the role of prevention in closer integration. Is there maybe any work been done in each of your areas about understanding the current level of investment in preventative activity in order to get a good baseline future activity? And if so, how have you gone about doing that? I mean, Terry, do you have a sense of where you are in preventative spend and where you're going with it? And then I'll ask Lee to say briefly something about the same in South Yorkshire, if I may.
I think we're quite early on that journey. Surrey County Council have commenced an interesting exercise, which is attempting to work with the districts and boroughs to do a mapping exercise, so we can identify, as you say, what is the level of preventative activity at the moment to give us a baseline, which we can then track and monitor. I think we have some understanding through our existing health and wellbeing strategies, where there is a strong focus in terms of that preventative agenda, and that's very much to ever a greater extent informing our approach to independent living, and trying to take a more preventative approach. But I think we're very early in terms of having a more developed understanding of exactly what the impact of our preventative spend is, and the extent of that activity. But I think we are moving in that direction. Thank you.
Okay, thank you. Lee, anything you want to say briefly?
Certainly, thanks, Andy. I think we understand what the NHS is doing. There's a really nuanced conversation about what are broader local government colleagues doing in that space, in the much broader offer that local government do. And then there's an even more nuanced conversation about what the voluntary community and social enterprise sector are compensating for. So we've got a very strong network and participation around the ICB board table about what the VCSE sector are doing, but it's a really nuanced conversation, Andy, about what they're doing about building community resilience, just food banks, reaching out in a very different way, it's really hard to capture the information on there without trampling all over it. So we understand what the NHS is doing, more or less, but there's a much more sophisticated ecosystem out there that's going on around community asset building and participation that we understand a bit about, but it's hard to track and monitor. It's doing the right stuff potentially, but it's hard to track and monitor it.
Yeah, okay, that's great, Lee. Thank you. Well, thanks to Lee and Terry for what's been a great start to our discussions. I know you can't clap and give thanks in the normal way from where you are, but I'll do the same on your behalf from here. So thanks, Lee, and thanks, Terry. And please feel free to stay around for the rest of the webinar if you're able to do so. So thank you for that. So the next session now, I'm delighted to introduce Richard McCallum, who's Director of Health, Finance and Governance from the Scottish Government, who will be followed by Alan Edwards, who's the Chair of the Audit Committee from the NHS Black Country Integrated Care Board. We're going to hear from Richard first and then Alan, and this session's about a whole system focus on outcomes. Again, thanks for your questions so far. Some really good questions and some good discussion prompted by that. Please carry on doing the same as we go through this session. So Richard, looking forward to your presentation when you're ready. Thank you.
Thanks very much, Andy, and hopefully you can see my slides. I've decided to try and show them myself, which feels like a bit of a risk, but hopefully folks can see those slides okay. I'm sure somebody will tell me if you can't. I am the Director of Health, Finance and Governance in the Scottish Government, and as I think Lee touched on, I think there's quite a lot of learning that we can do across the four nations, and hopefully it'll be helpful for you all to hear a perspective from Scotland this afternoon. I know it's certainly helpful for me coming and hearing some of the challenges that you're facing in other parts of the country, and knowing that we're not alone in some of those challenges we're working through. I'm going to just briefly say a few words about what we have in Scotland by way of a national performance framework, which really sets the context for our work around health and social care integration. I'll say a little bit about the model that we have in place currently in Scotland around health and social care integration, and then touch on where we're going next, and potentially some fairly significant changes coming over the next few years. But just by way of where we're starting, so in Scotland we have a thing called the National Performance Framework. It's been in place since 2007, and the version that you should see in the slides, or the summary that you should see on your slides, is the 2018 update version, which really focused around a number of key ambitions and aims that we have in Scotland, with a purpose of creating a more successful country where everyone can flourish. And one of the kind of key ways in which we aim to deliver the framework is through the integration of health and social care services. In 2014, integration authorities were established in Scotland, and I'll say a little bit more about the structure in just a second, but have combined budgets of about 10 billion from health and social care. The aim of the integrated approach, and I'm sure it's similar to what's currently going on in England, was to build a kind of opportunity for reform to meet the challenges we have in Scotland around an aging population, and really looking to shift resource to community-based and preventative care. As others have already touched on, there are differences in terms of how integration can and should work in local areas, but all integration authorities have adult social care as a delegated function, but some have children's services, some have mental health, and some have unscheduled care included within their integration schemes. Just a bit of a geography lesson. I'm sure many of you know Scotland well, but for those of you that don't, we have 14 territorial health boards in Scotland, and we have 32 local authorities. The integration authorities that exist in Scotland are broadly aligned to our local authorities, There is one, Clackmannanshire and Stirling Integration Authority, which is a combination of 2 local authorities. So we have 31 integration authorities as opposed to 32 local authorities. And as you'll see, in certain health board regions, for example, NHS Greater Glasgow and Clyde, there are actually multiple integration authorities reflecting the council areas. I think the point that I'd want to stress is while we have a focus on national outcomes, which I'll say a bit more about in a second, our geography is varied, and the challenges that are required to be addressed in different areas will look different. So Orkney, which is just the small grouping of islands off the tip of Scotland, not as far up as Shetland. We have a population of 22,000 people in that integration authority. Healthy life expectancy for a female is 77.5 years in Orkney, and it is clearly a very remote and rural population. Glasgow City, which is the number 14, the red square, if you can see that closely in to the squared area that's Glasgow, population of 635,000 people. Healthy life expectancy for a female in Glasgow would be 56 years, so some 20 years lower than it is in Orkney, and obviously a much more rural, a much more urban and densely populated setting. So local solutions to local areas, but with a national framework. The integration joint board model, which is what the vast majority of our integration authorities employ, is set out, and I won't go into too much detail here on the purpose of it, but essentially the council and the NHS board delegate specific services to the integrated joint board and provide the money and resources associated. The integrated joint board then, being accountable to both the council and the board, is responsible for directing both the NHS board and council in service delivery. So there's an integrated joint board that sits in between, if you like, the council and the NHS board. So we have 30 of those. We have one other model as well in Scotland, which is what we call a lead agency model, and that is in Highland. And Highland Council effectively delegates its adult social care services to NHS Highland as a lead agency model, and Highland is responsible, NHS Highland is responsible for the service delivery and operational responsibility. In terms of integration outcomes, so we have 9 national health and wellbeing outcomes, which are reflected underneath the national performance framework. Every year, each integration authority is required to publish an annual performance report outlining the progress that they've made towards these improving outcomes. There are challenges. Some of them are easier to measure and define than others. We were just talking about measurements of preventative improvements, and that can be particularly challenging, but integration authorities are expected to define how they are performing against these 9 particular areas. And I've picked on just a couple of areas where we're seeing real improvements. Inverclyde Council is just to the west of Glasgow City, which I mentioned earlier, but it is an area of high deprivation, and the Integration Authority has done significant work to address some of the very localised challenges. However, it has also been a lead and a kind of real clear pathfinder in relation to dementia whole system care. And I think one of the benefits that we have found in Scotland is, and again, maybe it's the benefit of being a relatively small country, 5.5 million people, is that some of those good practices around dementia pathways, we can really, if there is good practice seen in a local area, there is the opportunity to roll that forward and across other parts of the country. Equally in Orkney, which I've touched on, some of the work that the Integration Authority has done around its Home First programme and discharge to assess model has been excellent, and there's been a real opportunity to implement that, particularly in other remote and rural settings that face similar challenges to Orkney. And I'm happy to share these slides, which will give a bit more detail on those. And this slide includes some of those game-changing models that we've seen in Orkney. Lee and Terry both touched on some of the challenges that we face in integrating health and social care. And I'll just touch on a couple of things due to time, but you know, we have noticed, and there is a complexity in the governance and accountability arrangements, and it has taken us time to work through some of that. And actually, even it's not just how it actually is, but how it is perceived. So often in the Scottish Parliament, you will find committees, MSPs asking questions and assuming accountability for certain services in the wrong place. And so there's a challenge both in the actual governance and accountability and indeed how it's perceived. Planning is absolutely critical, and effective joined up planning, and we still have challenges around that, as we do around integrated finances and financial planning. And actually the different regimes that we operate in can create some challenges there. And actually just keeping that focus on the North Star. What are we actually trying to achieve here before we get into the squabbles and discussions about finance and governance and other things? But I guess to summarize, I would say, and I think this came up in the last presentation, my view has been, you know, before 2014, before integration authorities, and indeed over the last few years, where there is a will, there is a way. And actually where there has been strong, effective leadership, in some ways, to an extent, it doesn't matter what the governance arrangements are, what the accountability arrangements are. Yes, of course, they're important. But if there's a real joint commitment to improving outcomes in a local area, then real change can happen. And I guess, if I'm honest, I'm impatient when I hear people say we're at different maturity points or we're not as mature as others. My view would be we've got to get those mature relationships in place, because it's incumbent on us, for our citizens. Just very briefly, Andy, and I'm sorry, I've just, in the time I've got left, highlight that in Scotland we are moving to a next stage in our, I guess, our journey around integration. Scottish ministers have committed to a national care service following a review of adult social care. The integration authorities that we currently have in place under the legislation, we expect to be replaced by local care boards that will be directly accountable to ministers, rather than councils and health boards, which they're currently accountable to. And the desire really, and it links to that kind of national focus, is for ministers who have seen variation across Scotland to a strong desire for greater consistency, greater equity in terms of how services are provided. I'll not go into any more detail just now, but I'm very happy to take questions on that as things may come up later on. But Andy, with that, I'll stop sharing and hand back to you.
Thanks, Richard. That's great. Really, really good stuff. Some interesting stuff. And I've got a question or so myself, which I'll hold on to. Obviously, I guess Scotland started its integration journey arguably a bit sooner than England, and potentially its next step towards an integrated, national care service might be taking it sort of further from a statutory point of view. That's something just to maybe reflect on for now, but I'll hold that. Delighted to introduce Alan Edwards, who's the chair of the audit committee at the NHS Black Country Integrated Care Board. We must be one of the longest titles of an audit committee chair that there is around. But Alan, looking forward to hearing your presentation.
Okay, thanks, Andy. And Richard, I really enjoyed your presentation. Thank you. I'm looking forward to questions afterwards. Not only, Andy, am I a non-exec at the Black Country, but I'm also a non-exec in Providerland, in that I'm a non-exec at the Birmingham Women's and Children's Trust. So I get a sort of a view of both sides really of integrated care. I've called my presentation Measuring Success, because I think that's something we're just grappling with at the moment. Let's just see if I can get this thing to move on to the next one. Here we go. Sorry. Chris Hobson, when he was chief exec of NHS Providers, had a pretty regular saying of, when you've seen one ICS, you've seen one ICS. And the truth of that saying was really brought home to me in December earlier last year, when on 2 days running I was asked to attend 2 integrated care partnership meetings. In the first, in Birmingham and Solihull, I was standing in for the chair of Birmingham Women's and Children's Hospital, and the second I was at the Black Country Integrated Care Partnership meeting. Two very different types of meetings straight away. The Birmingham Solihull one was very formal. We all had microphones around a traditional sort of committee table. The Black Country meeting was the sort of classic drafty community hall, indeed being very cold that day, given that it was snowing in Dudley. And the second was about a group of representatives from a whole range of organisations in the Black Country. But what I particularly wanted to do with this slide is that the Integrated Care Partnership strategy that Lee was referencing earlier was the main item on both agendas. And in the first, the BSOL agenda was very, very long document, but had a very strong focus on measuring success and outcomes. And I've put in the slide here the 4 key metrics over a 10-year period that the ICP in that area are looking to deliver: increasing life expectancy, disability life, free life expectancy increasing, inequality decreasing, and excess weight decreasing. But it was supported by over 4 pages worth of outcome measures, with a 5-year trajectory of change for each of them. And indeed, those measures, I put them in the appendix to this document. We had individual metrics for each of the key aspects of change in the programme. So maternity, children and young people, long-term conditions, primary care, mental health, etc., etc. The next day, I was at the Black Country meeting, as I mentioned, a much shorter document, and absolutely no metrics of any outcomes at all, and very great pleasure and commitment from the Black Country that we got 4 priorities that we were all buying into and agreeing. So around workforce recruitment, education and training, children and families, social care, and mental health and emotional well-being. Great success from that perspective. But from my perspective, at the one meeting I was going, 4 pages worth of outcomes. Is that the right approach, given the change in the strategy around integrated care in the UK as sort of exemplified by the Hewitt reforms? The next day at the Black Country, are we sure we're doing this right when we've got no outcome measures? So what's the right approach, and what is actually happening on the ground? Well, I'm a member of the Finance and Performance Committee of the Black Country Integrated Care Board, and you might expect us to pretty well focus on the things that we're really concerned about as an organisation. And so from our perspective, these are the things that we're being measured. This is page 1 of 4 of all of the measures that we're being expected to achieve by the NHS at this moment in time. The focus is not surprisingly on these measures, because these are the measures that we're being assessed at by formally. We've got the quarterly system review meeting with NHS coming up on Thursday of this week, and I'll be there listening into the assessment. And that is quite important to us because it determines what is our performance category when it comes to the single oversight framework, and that gives us some freedom or otherwise to manoeuvre. So what is driving the ratings? So as I say, this is page 1 of 4 of all of the sort of measures that we're being assessed against. You can see in this graphic that we've got ICB measures as well as trust measures, and it's even more complex because within the ICB, we're not only being assessed by the population in the Black Country, the 1.2 million people that live there, but also the population of all of the major providers that they serve. So we have 4 acute providers in the Black Country, and we're a very significant importer of activity from the surrounding area, both from Birmingham, Staffordshire, Shropshire, etc. So it's a very complex picture. And I thought, just to illustrate just some of the 120 indicators that we're looking at for the Black Country, this is just one of them. And this is about the pathway of referral within 18 weeks. And as you'll see, the very significant decline since COVID, both within the wider ICS population that we serve and more in the Integrated Care Board, the Black Country purely population. And we've got this detail for every one of those indicators, but we're putting our focus, of course, just on those outside of reasonable tolerance levels and where our performance is not improving. And using even that criteria, there are 18 metrics of concern to us in the Black Country as we speak at this moment in time. So that's operational performance, but what about outcomes? Well, Core 20+5 is the national framework that we've put together within the NHS. This is an outcomes approach looking at the most deprived 20% of the national population as identified by the indices of multiple deprivation, plus the communities where they're experiencing poorer than average health access, primarily, of course, our communities in the Asian and Black populations and other ethnic minorities. And in the Black Country, we have got this highest concentration of the indices of multiple deprivation in the country. At almost 50% of our population are in that lowest 20%. Both ourselves and Birmingham and Solihull are the most densely concentrated areas of deprivation in the country. And of course, this approach is well researched, and you see in the next slide here that we know full well that when it comes to waiting, it's the people in our most deprived communities that wait the longest, and it's the people in our Black, Asian and minority ethnic communities who wait the longest for treatment. So we can see in real terms the impact that this is having on health inequality in practice. And so Core 20+5 is a pretty important categorization, if you like, of where we should be putting our energy. Given the very high concentration of South Asian community in the Black Country, we've gone beyond +5. We've created a +6 to recognise the very significant impact that diabetes has on our community in the Black Country. So we're attracted to the approach of taking this national approach to try and give us some idea of what an outcomes framework would be. But in practice, of course, we haven't actually got the data to do all of that. And so I'm really attracted to some sort of model that would give us an approach that's nationally comparable. And I was particularly attracted to some work that has been undertaken by IPPR, working with a firm of consultants called Carnell Farrer, as recommended by Matthew Taylor, the Chief Exec of NHS Confederation. And they put together an integration index based on approximately 30 integration indices. And their research really underpinned this message about the link between deprivation and ill health. And you can see here the metrics that are positively correlated with indices of multiple deprivation. Notably, of course, the proportion of preventable deaths, the inequality in life expectancy that Richard was referencing earlier, but also things that are causing all of that sort of ill health, like general smoking, and obesity. And so the index includes about 30 indices that Carnell Farrer are now tracking, and I've put in the appendices an example of the indices that they're looking at. And of course, disappointingly for us in the Black Country, given our position as one of the very lowest in terms of the levels of deprivation, or the very highest levels of deprivation, we've got the very lowest level of integration according to this index, which of course is very disappointing, but in that sense unlikely or not surprising. But what about performance at place level? And I thought I'd share with you some thinking that we've been doing at place level. And this is some analysis that's being done by Walsall Together. It's one of our most mature places in the Black Country. We have 4 local authorities that we work with. And this gives you some of the idea of the sort of, if you like, the drivers, the driver tree of well-being and well-being outcomes. And I think this is really quite an important bit of research that our colleagues in Walsall have been doing. What I like is this link between well-being and outcomes that the community is seeking to achieve. And we had an integrated care partnership meeting earlier this or last week, and it was showing just how important these well-being outcomes are, and how at the moment having enough money to always live comfortably is dominating the desired health outcomes in our communities right across the Black Country. And what our colleagues in Walsall have been doing is pull together a framework of measures that they think are really important, that link all the way back from an outcome that they're seeking to achieve about feeling good and functioning well and having sufficient money, is all linked to healthy behaviours, is linked to the affordability, is linked to poor budgeting, and ultimately linked to low literacy and numeracy within our population. Of all the key indicators of deprivation in the Black Country, this is probably the most significant. And you can see here that in the colours red, the areas where we have the very worst levels of deprivation when it comes to levels of literacy and numeracy, heavily concentrated across the Black Country. And that's clearly having a very significant level of impact on our communities across the Black Country, and therefore on the drivers that we're seeking to achieve and the improvement outcomes that we're trying to achieve longer term. So what's the solution? So from my perspective, I very much support the CIPFA recommended approach, and we've just heard a really excellent example from Richard of some form of national outcomes framework. And anyone who's got experience of working with how the NHS operates, or indeed how rival local authorities in a sub-region work, will know that having some sort of framework for comparison is absolutely essential and helps us to enable shared learning about what actually works on the ground. And from my perspective, it would be really ideal if that could be encapsulated in the UIT review that we'll be hearing more about later this week. But surely there must also be an opportunity for some flexibility at place level, as we've seen in the Walsall example. And I think that really that would give us, if that was agreed in the UIT review, it really would be excellent if we could have chance then to put that into practice as we develop the joint forward plan. We're developing the first drafts for the end of March, but we expected to have the final document by the end of Q1 of the coming year. And it really would be excellent if we could pull those together, ready for the 5-year joint forward plan. Otherwise, I fear that Donna Hall's recent comment about ICP strategies being full of motherhood and apple pie could be translated into these joint forward plans with I fear, similar ingredients. I hope that's helpful, Andy, and that gives people food for thought.
Yeah, thanks, Alan. Fantastic stuff. As well as illustrating clearly the difference between two neighbouring integrated care partnerships. For those who don't know, Birmingham and Solihull and Black Country sort of share I won't say borders, boundaries, not very far apart. It also illustrates that integrated care isn't just about frail elderly discharged from hospital to free up hospital beds, which is what much of the national discourse is about. And those measures around health and well-being of population linked to outcomes is really, really good to see and hear about. So thanks for that. A couple of questions, if I may. One for Richard. So you talked about sort of England and even Scotland. I don't know whether there's the other way around. In England, we've got numerous central NHS performance metrics which are being set by NHS England. Do you have any advice from the Scottish experience in terms of how to balance those with a focus on sort of more local stuff? So how do you get the balance between national and local based on the Scottish experience, given I think you're probably further ahead than us in having that national framework with some local delivery arrangements?
Well, I think my first point would just be to be realistic about some of that, and just as you have a number of national performance standards at a central government level for the NHS, so do we as well. And I think there's that will continue, and that won't change. And sometimes they can be focused on the very immediate and feel that quite short term in terms of their focus. But I think we all need to have that realism that probably won't change anytime soon. But I think alongside that, and I think this is where it has been helpful to have a kind of national outcomes framework, is to have that kind of, for want of a better word, that guiding North Star, I think has helped everyone. It's helped in some of that dialogue with ministers, with politicians. It's helped with discussions with the public who get it, I think, in terms of what local systems are trying to do. And I think, it keeps that focus in local systems. Yes, there will be those immediate performance targets and expectations around that, but it gives us a way in some ways of balancing that with some of the long-term plans that we have as well. It's not easy, but I think it's helped us to move that conversation on a bit.
Yeah, thanks, Richard. And Alan, I guess really struck by that Walsall example there. And given my comment about much what we hear nationally is about sort of we need to free up hospital beds by getting people moved into alternative settings, mainly residential or domiciliary care, that sort of top-down approach. My view would be actually central government need to learn from what's going on in local places. So have you done any work about feeding up nationally some of your emerging local experience of practice, or thoughts about how we might do that in other areas for those who might not be as far advanced as you are, appear to be in Walsall, if not the whole of the Black Country?
Sure. I mean, it's a constant battle, isn't it? How do you get over good performance and share good performance? And I think there is, if we're not careful, a danger that we don't share our experience and take a sort of not invented here approach. That's one of the thoughts in my mind that I'm pursuing at the moment is, can we do something on, national TV, national radio? The Radio 4 Today programme looking for guest editors is sort of a thought, why not feature the Black Country? We're the most deprived area in the country. So, the things that we're doing would be an excellent sort of way of doing that. So I do think that's one of the ways that we've got to do that. And we've got to move away, as you rightly say, from a focus on just can we reduce, can we increase the number of people moving out of hospitals, and we've got to put more money into prevention. At our integrated care partnership meeting earlier in the week with a whole group of people from the housing sector, from the voluntary sector, from local authorities, that was overwhelming the message to us. You've got to give us an opportunity to tackle these issues and to free up some spending for it. And it's so difficult, as Richard was just explaining.
Yeah. So Richard, just building on a point that was made in the last session about do we understand preventive spend, and therefore over time can we track preventive spend, and hopefully more spending on prevention would lead to better outcomes. I guess that's a theoretical sort of construct rather than something which actually is probably proven by evidence. But I just wondered about the mechanisms in place to ensure that sort of finance and funding stream follow, and whether you've got anything in Scotland that we can sort of maybe think about or learn from in terms of how do investment decisions get made, and how do we ensure that funding follows the priorities that are being set either by the national framework or by each of the sort of integration areas.
Yeah, I mean, I think what we've been able to do, or what we have in Scotland, is some examples of where that's worked well or is starting to work. But doing that on a kind of a more whole system, whole spend basis is where it would be really good to get to. And I think so often we're focused on a number of specific areas. So we've had real challenges, as some of you may know, around the number of drug deaths there are in Scotland, and actually some of the interventions and changes that can be made are quite powerful. And actually, some of and the investment that we've put towards tackling the drug deaths crisis we have in Scotland has been some of the information that we've pulled through from that has been really quite interesting and quite telling. So that's been a good example. We're obviously on a journey with that, and it will continue. We'll continue to see where we go over the next few years. But I think so. I think in certain areas we've got some pretty good data, and we've got some pretty good tracking of that. My concern was always more almost at a macro level and saying, we spend 19 billion on health in Scotland. How do we make sure at that macro level we're investing in the right areas? And I suppose that's a challenge we have at a central government perspective. But we do have some good examples, but as I say, on more specific areas. Thanks.
Yeah. Okay. One of the examples that was actually it was in the text Q&A that you answered on behalf of the person asking the question was about your discharge to assess model that works so well in Orkney, and could it work well in areas such as Glasgow? I think you'd said potentially it could, but I just wonder what are the differences in applying something in a sort of a rural area, very rural area like Orkney, to a more densely populated area, because there'll be similar parts of England where things in a rural area will be different to in an urban area. And just wondered, have you have you learned anything that as to what would be the ingredients of making it work, or challenges which might mean it might be different?
Yeah, I mean, it's not necessarily directly linked to that particular example. I mean, one of the interesting things that we've found in more rural areas where there isn't a district general hospital is people don't go to hospital as much. To be perfectly blunt, people aren't willing to travel that distance. And actually, when you get to very urban areas like Glasgow, people are more likely to go to hospital. It's an interesting practical point. People's first port of call is to go to hospital, whereas actually in more rural settings it's not. So how what is that kind of psychological behavior in some ways that makes that difference? And that's been quite an interesting thing to work through. I think as well the kind of harnessing of digital technology has been a really important thing it's been true for all areas, but I think particularly for our more remote and rural areas has been really beneficial. But some of the opportunities there are in bigger urban bases like Glasgow are greater. And I think it comes back to that point of having those national outcome standards, but applying it locally. And I think that's the key in so much of this.
Yeah. Thanks, Alan. I noticed I can't see the slide in front of me, but there was something on your Walsall slide about sort of digital technology as a maybe enabler or a barrier to better outcomes and well-being. I just wondered, do you have any examples or experience from the Black Country about the extent of online approaches or telemedicine type approaches or digital approaches to health and well-being that you're starting to work with?
Yeah, I mean, one of our programs is very much about making available to people in the most deprived communities access to the technology. So sort of reconditioning second-hand kit and making it available is certainly one of the things, and sort of teaching people to use the NHS application. So, that is one of those techniques that we're using. I just sort of looping back to one of your earlier points. I think one of the things that I've been saying to our sort of academic community and sort of policy specialists is, tell us the top 3 to 5 things in each of the priority areas that are the biggest value for money changes that we can make that will operate at scale. And I think that is something that we all need some sort of insight as to what really works, what's good value for money, and what will really drive those outcomes. And that's where we need to be putting our bets. But as we were saying earlier, frankly, we haven't got a lot of money to do that. So it's finding the things that will really make a difference.
Yeah, excellent. Thanks, Alan. That's a really good way in which to conclude this session. So can I thank Richard and Alan for 2 brilliant presentations in the sort of usual way on your behalf. We can clap from here, although the rest of the delegates can't do so. So thanks ever so much for that. Thanks for your questions coming through as well. We're now going to take a break for comfort break. Could you reconvene at 3:15? Please don't log off, but we'll start again at 3:15 with a session on putting the principles into place, where we'll have Carol Cully and Richard Douglas giving us their insights and expertise. Thanks very much indeed.
Andy, can you just turn off the recording, please? Thank you.
So Louise, do I need to pause it or stop it? I've got
Pause.
pause. Okay, welcome back. It's good to see we still have approximately the same number of delegates on the call as I had before. So I'm assuming people are back on time. So thank you for that. So for our final session then, which is called Putting the Principles in Place, I'm delighted to welcome two fantastic speakers who are going to share their insight and experience. We're going to start with Carol Cully, who's Deputy Chief Exec and Chief Finance Officer at Manchester City Council. And as many of you will be aware, Manchester have been at the sort of the forefront of the health and care integration agenda as part of the sort of the Greater Manchester scheme. I know that Carol's going to speak about GM as well as Manchester as a city, maybe a bit of both. And then Carol was swiftly followed by Richard Douglas, who's the chair of NHS South East London Integrated Care Board and a previous director of finance at the NHS. So without further ado, I'd like to introduce Carol. And Carol, when you're ready, looking forward to your presentation. Thank you.
Thank you. And as anybody who could hear us during the break will know, I've got a bit of a cold sinusy thing, so please bear with if my voice goes or gives up halfway through this, or if I sound even more random than I usually do. So just to make a start on the next slide, please. And Louise is kindly doing my slides, so you'll hear me slightly clunkily saying next slide, or please move on as move between them. Those of you who know me that will know technical brilliance isn't always my strong point. So just a little bit of context. I think our integrated care system was formally established in July 2022. As I'm going to come on to, that really does build on the devolution agreements that Andy referenced. And I always think it's worth starting a presentation with what we're trying to achieve. So we had the burning platform of how do we change our system. We still have that burning platform, but we're very much here on our purpose for improving the health and well-being of people in Manchester, strengthening the social determinants of health, ensuring the provision of safe and equitable services and try and make sure there's not variation, people and communities feeling like active partners, and to ensure a sustainable system. It's also worth noting that GM as a city region is a Marmite city region as well. So no small ambition there. Moving on. The focus of this afternoon really is, I could talk about this until the cows come home, there's an old saying, but what I'm going to do is just focus on how the governance and financial arrangements work within Greater Manchester and some reflections from it. So the next slide, which is not the easiest to necessarily read on screen, but sort of talks about the governance at the GM level, and then I'll come on to expand how that works at place, because ICSs are by their very nature, and if anyone's read the publication as well, are quite difficult beasts to get your head around and can vary quite significantly from place to place. So the key part of the Greater Manchester arrangements, no big surprise, formed around the Integrated Care Partnership Board, which brings together all partners, including the local authority and the Integrated Care Board with the NHS responsibilities. This builds strongly on the arrangements we had in place during devolution, and it's worth briefly recapping on those. So under the 2016, I think it was, it feels like forever ago now, Memorandum of Understanding, we formed a Greater Manchester Health and Social Care Partnership, which brought together local authorities, health and care providers, all of our major NHS partners, CCGs and foundation trusts in particular, into a single partnership underpinned by Provider Federation, where all of our main provider trusts, largely foundation trusts, worked at least a little bit collaboratively towards decision making, and In each locality, that was underpinned by integrated commissioning arrangements, bringing together the CCG and the local authority. The moves towards a single hospital service in the localities and some of the reconfiguration of the Pennine and Manchester Foundation Trust very much reflect that, although it would be remiss of me not to say MFT covers Trafford as well, and integrated delivery of community health and social care on the ground, which we've got through our Manchester Locality Care Organisation. And those were underpinned by Section 75 with the Committee in Common for Commissioning and delegation of some of the social care and finance functions to MFT to enable the LCO to act like a single provider with delegated functions in the Section 75 and an aligned budget. And then underpinning that, we had integrated neighbourhood teams that sought to bring together care and primary care. And I've reflected on that slightly because I think as a system, we sometimes take for granted some of those pillars of integrated working that have been quite a long time in their development. As we move to the ICS, those principles of operating at the Greater Manchester level locality and neighbourhood have been protected and to some degree reinforced. So we've got the Greater Manchester governance with the Partnership Board, Integrated Care Board, very much underpinned by a Joint Planning and Delivery Committee and various committees, forums to help the development strategy and policy and accountability and governance at the Greater Manchester level, with the read across to what that looks like by locality. And by locality, it's an easy shorthand for us to use because all of our localities are coterminous with the local authority areas. So if I move on, one of the key planks of the kind of integrated care system and the links to the localities is having a single accountable person in each locality. Our chief exec won't thank me for just having described her as a plank, but in most of the localities in Greater Manchester, that single accountable person is the local authority chief exec, and that is supposed to very much reflect the local authority role of conveners of place. And Joanne has a joint contract, well, she has a local authority contract, but with the NHS elements in there as well, around her NHS accountabilities. Although I've pointed out the NHS can't sack her because she's a statutory officer of the local authority, although she could be removed from her NHS duties. Moving swiftly on before I dig myself into any more holes on that, because chief execs tend to be fairly busy people, each locality has a deputy place-based lead who is on an NHS contract, and it's almost the equivalent of an SRO, day-to-day SRO, with overseeing the running of the NHS arrangements. So if we move on to the locality-based governance arrangements, in very simple terms, GM have been working on their new operating model, and we are looking at a more centralised model for many of the ex-CCG functions, needing to achieve economies of scale and consistency, along with a number of other activities that enable GM and locality to work effectively, including the scheme of called it reservation and delegation. I'm not sure that's quite right. Yes, it is. The SWORD, which was agreed in July 22. Delegations were originally to the place-based lead, but as we go live from April 2023, they'll be to our local partnership board. And those place-based arrangements, which were operating in shadow form last year, go live in April 2023, with our Manchester Partnership Board established with the delegations and decision-making body for the arrangements at place. That is a kind of hybrid model. It's a subcommittee of the ICB and will retain oversight of the commissioning and financial Section 75 arrangements which exist at the locality level. And one of our key challenges is how we fit our locality decision making and planning into the GM framework. Moving on, another fairly busy slide, but this is the standard one we use to describe the accountability and assurance arrangements at the Manchester level. And obviously we need our very own clear governance arrangements to underpin this. So as said, our locality board is the Manchester Partnership Board. It's chaired by the leader of the council and brings together all of our key partners in the same way at GM level the GM Partnership Board does. That's underpinned by a Partnership Board support team responsible for coordinating strategy development, financial support, We have the clinical and professional advisory group, which we all have to have in place, chaired by Sahel, who's also a member of the local care board, local care organisation management team. And what we're trying to do is retain that focus between the here and now, which is pretty tricky, and the longer term determinants of health, being a Marmot City region, being a Marmot City, and how do we balance decision making between prevention and longer term determinants and the here and now with the pressures on the social care and hospital system. The Manchester Provider Collaborative, so we all have a provider collaborative at place level, brings together all of our key provider colleagues, and purpose includes oversight of the local care organisation, as well as that clear delivery plan across all of the providers in Manchester. Moving on, the funding flows, it should always be form follows function, but in understanding the integration arrangements, the financial arrangements are key, and worth bearing in mind that that includes oversight of particular functions delegated to place, and I'll come on to those in a minute, as well as how the arrangements work at the locality level. So having taken from the quote from the publication, I'm going to move on to explain how the funding flows that underpin this work. I am sounding quite dry even to myself, but please bear with me, because I think one of the interests for me in the integrated care arrangements is how they do vary from locality to locality and from ICS to ICS. So stating the bleeding obvious, the GM integrated care system and the board have accountability for the NHS budgets within our area, and they operate under their own board terms of reference, scheme delegation. That is mirrored through to the locality leadership. And where we're really navigating through at the moment, and I'll kind of come on to this in my final slide on the issues, is the GM level decision making. So for example, on acute provider trust, the contract arrangements are likely to be negotiated at GM level, but the impact and some of that system planning required is likely to operate at GM level, at Manchester level. So it's that distinction between working within the GM framework and the planning that we need to do at the locality level. In terms of the very specific funding flows, the responsibilities that are delegated to localities include what I'd call, being an ex kind of head of finance and social services, the volatile placement budgets, including things like continuing healthcare, learning disability and mental health placements, responsibility for meds management or prescribing with the key primary care contracts themselves handled at GM level, and VCSE grants and some of the support functions. We also have the locality employee and leadership budget. All of these remain on the ICB ledger, and we have the delegations and are in effect, I'd say, a cost centre of the ICB. We have the section 75 with the integrated care system, which is a requirement around the Better Care Fund and the discharge grant, and indeed we've just updated that to take to our exec next month. And then we have the delivery of our adult social care and community health services. Here, as I said before, our section 75 agreement is between ourselves and Manchester Foundation Trust. So we have the delegation of duties into the trust to enable them to operate the LCO, which is hosted by them as a single organisation, but the section 75. And whilst those arrangements have been updated, they are still operating as they were in devolution times. And worth pointing out, it's an aligned, not pooled budget, which helps hugely. And then we have delegated a number of our statutory functions, probably since I joined Manchester in 2001, to what is now the Greater Manchester Mental Health Trust for mental health services. And I'm just going to put my phone onto silent. I should have done that before I started. So those are basically how the funding flows work. We're a cost centre of the ICB. We have our section 75 for the Better Care Fund, and we have our locality arrangements, which have evolved but not fundamentally changed since devolution. At GM level as well, you've got the decision making by the Finance Committee and the board. Supporting that, there's their finance leadership group and something snappily called FAC, or the Financial Advisory Committee, which brings together representatives from the local authority, the provider DOFs, and the GMICS to look at how we do that system-based planning. And for my sins, I'm one of the local authority representatives. So moving on, and you'll be pleased to know I'm now at the wrapping up stage, but I don't want to skip over some of the key lessons and some of the key issues that's just worth picking up on. I think it's really tough, isn't it? And I sort of caught the end of the last discussion. How do you maintain the focus on the longer determinants of health and prevention whilst dealing with the finance and performance pressures of the here and now? Not proud of this, but as GM, we probably have one of the biggest deficits at the moment in our ICB in the country, which is running at around 6% of our 2 billion or so allocation, and a huge task in hand on how we bring that back towards balance. Number of issues in there, and I think, as with any kind of ICS, you always get that mix of productivity, efficiency, scarring from COVID. Have we stopped all the things we should have stopped? I would say in the Northwest, some of our funding per head, given the levels of deprivation and entrenched health conditions, is quite challenging. And the challenge to ourselves is, have we bitten the bullet on some of those decommissioning decisions we should have done previously and need to do now? So trying to get the balance between those things, and certainly at FAC, we're very focused on the funding plans that have to be submitted for 30th of March, I think it is, and how we get ourselves into balance. But then how do we look at those longer term determinants and the longer term sustainability, and how do we get into the space of discussing some of those decommissioning decisions? Then there's it's very much how you balance as well. Every place is different, and as we move into the ICS arrangements, it's quite nuanced, but as we tried to move into more standard agreements with localities, every place did things slightly differently. Funding arrangements in each locality, relationships with local authorities and CCGs were very different. And there are a lot of legacy issues arising from that, which we need to pick up on. The governance frameworks are invaluable in helping us navigate through it, but that is causing us some challenges as we move to greater consistency across GM. As I said at the start, I think we take for granted a lot of the arrangements we've put in place, but that's not with any arrogance. I think sometimes being longer established, there's more learning to take from places that are newly established and kind of working through these arrangements fresh. But we do have a lot to build on in terms of our integrated commissioning and delivery. I think the financial integration, through what was previously MHCC, by the way, I am so good at using acronyms and not explaining them, was the joint commissioning partnership with our CCG and ourselves, and also the work with the local care organisation has already set the groundwork. I think some of the big lessons are, as it goes on to say, some of those traditional barriers around tax and everything, VAT in particular, secondments, pensions, those remain. But what we have to do is try and make the most of the arrangements and deliver the maximum we can for our residents. And when we're all being so incredibly risk averse with our constrained budgets at the moment, it's not losing sight of the greater good and what we can achieve. And then it's that balancing act, isn't it, between what decisions are best made at GM level, but how do you retain the locality focus, the experience from neighbourhoods and expertise? What should we as locality place boards have oversight of? And then finally, how do children's services really fit into all of this? A lot of our more prevention, public health services, for example, are very focused on children's, and it makes sense to have an integrated system, but some of the social care responsibility is very different. And we're just kind of navigating through how we build in the best of our children's locality model at the moment. That is more than enough for me. So I'm going to shut up now. But hopefully that gives a bit of a flavour of what we've got and what some of our challenges are.
Thanks, Carol. That's fantastic stuff. Some really comprehensive and detailed issues. And I think those key lessons on your final slide, I'm sure will be relevant and resonate with others. So thanks for that for now. I'm going to hand straight to Richard. So Richard Douglas, whose current role is chair of NHS South East London Integrated Care Board, who's going to give us his perspective, and then we'll have a Q&A session with both Carol and Richard. So please continue to send through your questions you might have through the Q&A. So Carol, if you could turn your camera off, please, and then Richard, you should then hopefully occupy the screen. Thanks, Richard.
Thank you very much for that, Andy, and hopefully you can see and hear me.
Yeah.
All right.
Yes.
I think as Andy said earlier, I'm not going to use slides today. You're just going to have to listen to me talking. So if you want to keep a record, you want to have slides to look at, you're going to have to use a old-fashioned pen and paper for this. Colleagues in the earlier sessions got a partnership and prevention, a focus on outcomes. Carol and I get governance. Now, I'm not quite sure what we did to deserve governance and accountability, but it is something that we need to talk about, and it's something worth talking about. So I've been asked particularly to speak about a principles-based approach to place governance and accountability. I'm going to do that in quite a general context about why I think this principles-based approach is what we should have. But I'll also bring in some of the context of South East London to make it real, hopefully, to people. So South East London ICB, 6 London boroughs, as it says, in the southeast corner of London, population about 2 million, some very large NHS organisations within there, Guy's and St Thomas's, King's, South London, Maudsley, big inflow of patients and a big inflow of funds as a result of that, and a real mix of different types of places. Ones that have very, very young populations, ones that have older populations, ones with high levels of deprivation, ones with lower levels of deprivation, but a real mix in a relatively tight geographical area. Now, I'm going to come at this from the perspective of both an ICB chair in London and someone who, in a former life, had policy-making responsibilities. I don't want to repeat what's in the CIPFA document, because I basically agree with everything that's in there. But I want to focus on 3 things: what a principles-based approach means, and what it means to me about a principles-based approach to governance. Why I believe this is the right approach for us to take as we establish ICSs. There's a focus here for me, particularly on principles-based approach at place level, but I could apply a very similar thing actually at the level of the entire ICS. And then what challenges such an approach presents. So I take each in turn. What do I mean by a principles-based approach to place-based governance? What I mean is that you have a system of governance that focuses on intent, that focuses on the fundamentals of actually what we're trying to achieve through our place-based teams, rather than something that details how we do it. We're aiming to improve health and care for our populations and to give better value for the public pound through improved working together. At its simplest, that's what this is about. And governance has to focus on that basic purpose, those basic principles. Now, I don't mean here that the how, the sort of rules and procedures, the schemes of delegations, the terms of reference for committees and everything else shouldn't be set at all. Clearly, you need that structure within which to work. And I don't mean that as part of that there's nothing there, that every decision is just taken in isolation at the whim of a local leader. But I do mean that those rules and procedures should be set at the level of the place, rather than at that national level or the level of the ICS. And I think this is really, really important. And I don't mean in this again that those rules and procedures should be established locally without any context or any accountability or challenge. I don't say in South East London to Bromley, go off and devise your own governance and just come back and tell me something later on. I don't say that to Lewisham, I don't say it to Lambeth. They need to be developed in a way that is consistent with agreed principles and can demonstrate how those principles will be enacted in local circumstances. So in establishing that governance, there's freedom within a framework, and freedom, as I say, that then needs to demonstrate adherence to a set of principles. There is perhaps a debate to be had, I guess, about what those principles should be and where they should be set. Should they be set at a national level? Should they be set at the level of the ICS? Should they possibly be set at a level of a region? But I think the fact that you need a set of principles, that they should provide a framework, in my view, should be a given. To sort of explain a bit about what I mean by principles, in South East London, we've built our governance, and that is the governance at place level, at ICS level, a level of how programs boards work, everything around three key principles. And they are, first of all, the principle of partnership. We are a partnership of sovereign bodies. We come together to achieve something greater than the sum of what those partners could do individually. And all partners have a voice and all partners have responsibility. That's how we describe that partnership principle. Second principle we have is subsidiarity. And this means that all issues and decisions should be dealt with at the most local level, consistent with their effective resolution. So we start from the basis that it should be local, but local consistent with effective resolution. So there will be some things we will do at the level of the ICS, not at the level of the place. There are things particularly around digital infrastructure, a number of things around workforce that will be done at the ICS level. But our general approach is it should be as local as possible. The third principle then, and a very important one for us, is the principle of accountability. And we describe this as we value both supporting each other and being held to account by each other and our wider partners. So in setting this approach, we're not giving a free-for-all for everyone. People are held to account for what they do, but there is a big focus on that, within that, on mutual accountability, on partners holding each other to account rather than looking up the system to be held to account. Now, as I say, we've sort of threaded those principles through everything we do in South East London. You'll see them in all our board committees, our terms of reference, our schemes delegation. You'll see it in our job description, our job adverts, because we want that thread to be there in everything about our approach. We're a year in, I think, as people said, we're almost a year in as a statutory organisation. And like lots of people in the NHS, we're looking at our governance and thinking what's worked when we've actually done this in practice. We do have a habit of occasionally pulling the flowers up to look at the roots to see that they're growing all right. But I think as we look at this approach, there's one of the things that strikes me quite a bit on this is I think in ours, there's something missing still. I think those three principles are great. I think they work well, but there's something missing to me about making the best use of the single public pound. So as we go into our sort of annual first year review of this, I will be looking to sort of push and check whether we need to get something in, say something that talks about how do we get best value from a single public pound. We talk about that a lot, but I don't think we've really threaded that properly into our governance. Now, they're the ones that we use at South East London, but equally, I think on a principles-based approach, you could use the type that are listed in the CIPFA document around shared vision, collaboration, transparency and openness, again, subsidiarity. I think these are all quite similar, but you need something that frames a set of principles that supports what you're trying to do as an ICS. Why do I think that principles-based approach is the right one? Three reasons I'd have. First of all, it focuses on purpose. It makes you think about purpose when you develop these structures, when you develop your governance. It makes you think about why we have created local place-based partnership. It makes us think about what we're actually trying to achieve through place-based partnerships. And rather than us doing what we often do on these, just ticking off another box in our checklist, the legislation requires us to have place-based partnerships. So we establish them, we tick the box, and we move on unthinkingly. This makes us think about purpose, and it makes us think about purpose continually. Second reason I think this is important is a principles-based approach allows us to recognize and reflect the differences in our places, differences in populations, in configuration of services, in geography, in history, in politics. You know, all these different things are at play, even in a geographical area as small as Southeast London. One size can't be made to fit everything. If we tried to describe in detail and create a set of rules for the governors of every place in the country, we'd have a governance rule book that filled a room, and it would never work, and it couldn't operate. And this is about both those hard factors like geography and structure, but I think it's important to remember as well the softer factors around culture and history as well. We're all driven by that in some way. That past shapes what we are now. So I think there's a really important reason here around allowing difference. Third, principles-based approach allows these structures and our approach to evolve over time. We're still in the foothills of this policy. What's needed now, what may work now, is probably not will be needed in 1 year, 2 years, 3 years, 4, 5 years time. Things will change both at a national level and differentially across the country. If you go for a rules-based approach around a principles-based approach, you start to fix things in aspect, and you start to create basically what should be a minimum set of standards become the maximum, become the only thing you do. So I'm absolutely clear that this principles-based approach is the right one. But it doesn't come without challenges. Carol before mentioned about some of the key lessons in Manchester, and as I reflected for doing this brief presentation, really thought about, well, what are the challenges been to us in trying to adopt this principles-based approach? There's a number. First, it's not easy to implement. We all grumble about it, but being given a set of detailed rules and a highly specified model constitutions and being told to follow them is really simple. For us, it gives us something to complain about and grumble about, but we don't have to think. Thinking about how you apply a set of principles in a particular context is hard, and it requires local leadership to come together, for local leaders to set aside time and intellectual energy to agree how they want to work and how they want to make decisions. And to do this at a time when thinking time is crowded out by day-to-day doing. We spend a lot of time at the start of our formal, actually before our formal establishment as an integrated care board, trying to bring our senior leaders together on organisational development work, bringing together not just our place-based leads, our ICB leads, but also leads of our provider collaboratives, our primary care teams, really trying to think through quite hard, are these the right principles and how will they work in a local context? So this takes effort. I think the second challenge is it can't be done in isolation. You can't have a principles-based approach at a place level if other parts of the system focus on rules. And I think this is a real challenge for us at the moment. You've got to have a principles-based approach, cannot work effectively for other parts of the governance framework, whether it's regulation by CQC or oversight by NHS England, is entirely rules-based. And I think at the moment we're in quite a struggle on getting these two different approaches to work in sync. I've worked at a national level, so I know it's very tricky sometimes to to allow that freedom to operate in different ways. And there is, over time, always a press to standardize, to remove what people say maybe unjustified variation, but in some cases is just variation. So I think at the moment we're still in that forming bit of struggling between how do you match a local principles-based approach to a national rules-based approach. I think the third thing is a principles-based approach can add complexity for some organisations and bring the risk of unnecessary bureaucracy. If I think in South East London context, I've had this conversation with a number of our provider leaders. Most of my big providers operate across at least 3, maybe 4, maybe 5 different places. If in how they relate to those places, how the financial flows work, how the governance works, they are dealing with different approaches, it adds complexity to what they do, because it inevitably leads to variation across those places, and it can add additional layer of complexity for our providers, which I think we're yet to resolve. And I guess the final challenge on this, and one that I think is a particular one within NHS organisations, is this approach requires a degree of trust. Now, people have talked about maturity of relationships, evolution of relationships in the other sessions today. How quickly you can get to that position of trust, real trust between organisations within the ICB and between the ICB and the national bodies is critical to making this work. So in conclusion, I'd argue I sit for having a document, and I would commend the document to you, that we should not be trying to impose a single model on how places should operate within ICSs with one rule book that we can all just take off the shelf and use. But this is not to say there should be a free-for-all. There should be a very clear set of principles for ICS and places within them. And that really we need to develop then the detailed rules in a way that's best designed to deliver our purposes in place. Doing this isn't an easy option, but it is in my view the best one. To quote from the old New Labour mantra, if I can say old New Labour, what matters here is what works, and I think here both of those are best determined locally. So I hand back to you at that point, Andy.
Thanks, Richard. Fantastic exemplification of what governance means in reality. So thank you for bringing that to life in a way which makes sense in sort of plain language. That notion of start with the what rather than the how, and having some local definitions around what that means. Now, the fact that partnership is about what you can do together, subsidiarity being about the most appropriate sort of level, starting with what's most local, and accountability being about both support and holding people to account via challenge. I think some really, really good, if you like, illustrations there, which I'm sure people can think about and develop locally. I think you talked about making best use of the public pound. I think Carol in her presentation talked about there's a 6% deficit in Greater Manchester, and we've had a question in the chat about value for money across the sort of system. And I guess there are politicians in the public who think both the NHS hasn't got enough money and is inefficient. So I think, show me the money, to coin a phrase, is where we've got to, which is maybe no big surprise for a CIPFA webinar. But just in terms of the financial aspects to it, we've talked a lot about outcomes and health and wellbeing of populations, but ultimately there's a system here with limited or scarce resources. How do we make integrated care systems deliver better value for money? And actually, who should hold the ring in terms of making assessments about value for money across the whole system? I don't know whether Richard or Carol, you want to start with start with that one. Where's that best done in terms of that holding the ring for value for money? Do you want to go first, Richard, and ask Carol maybe to come in from a GM?
Okay,
perspective?
so holding the ring about value for money. I would worry if we started at an integrated care board level trying to assess the value for money detail of everything that each individual organisation or each place does. Yeah, frankly, you've got well-paid people at place level, at local government level, and heading our trusts that you can't rely on to make the general basic value for money decisions about what you do. It's a bad job. If you're thinking about sort of allocative, how do you put your big pot of money out, then I think that becomes quite a different question. I think that at the very highest level, I start that is an agreed thing, an agreed approach to that at the ICB level. And I think I think Lee had, if I think of my ICB board level, the big difference from the world we're in before, where there's a bunch of commissioners, we have got people with commissioning background, we have got our provider organisations, we have place-based representatives, we have local government there. And you start to make that allocative decision, I think, with that group of people at that level. I think there are then some things around value for money that I think there is a different approach. And why I bring up this question of public pounds a lot, and I don't think we've got this at all right yet, is that's the context in which I want our places to think. And the example I give, and other people will have probably better ones than me, is part of our strategy. We have a focus on children and young people's mental health. It's one of the key planks of our strategy. A lot of the work to support young people, children's mental health takes place in schools. At the moment, you have potential funding for that comes from the schools themselves, often through the pupil premium. You have something that comes from local government. Often you may have something that comes from the NHS. What we've not been very good at thinking about is, if I put all those pounds together from these three different organisations, am I getting the best bang for my buck in each of my different places? And historically, there's been a reluctance to look at it in that way, because the health side would sit there and think, well, why should I think about that? Because if I start thinking about it, the schools will start using their pupil premium for something else, not for this. And so that's the bit I think we've still not quite got right yet, Andy. And that's why I want to bring that one public pound issue to the fore.
Okay, thanks, Richard. Carol?
Thanks. And I think Richard brought to life some of those tensions in principle-based governance and why that's important in a really powerful way. Starting the answer, it's, what do we mean by value for money? We all mean very different things. And my worry is it's getting that balance right, so it doesn't all focus on allocative and contracts and balancing your allocation within the financial year, to how do you start to take a longer term view that looks at the whole agenda around health outcomes, that makes us more sustainable, and how we can plan across partners. I think one of the things this has really brought home to me over the years is the difference in cultures, which is quite easy to underestimate. And when there is such a national system of balancing to the allocation and key performance indicators, which don't always reflect what you would need in a London or a GM pound, it gets quite difficult. And that's where I think the points that Richard made about trust are so important, and principles, because otherwise you get driven to looking at the key performance metrics, standard NHS benchmarking, but you miss the big picture around, is this helping us deliver sustainability in the NHS system, and are we leveraging resources in the most effective way to help us achieve those outcomes? I think it's fairly early days to look at how across ICSs up and down the country we could learn from each other in doing that, but I think we lose sight of that at our peril.
Okay, thanks, Carol. I've had a question coming through about what can local authorities in particular do to balance firefighting against current pressures and investing in prevention? I mean, we heard from Terry earlier on some practical things that from Spelthorne, but they're obviously a council without social care responsibilities. If you're a council with social care responsibilities who understands the importance of prevention, but actually can't find the headroom or the space within its challenge budgets to do that, any advice or thoughts or practical examples about how you get that balance right between the here and now and investing in prevention? Any examples from South East ICB or Manchester, or indeed any of our other panelists who are still on the call?
Let me come in. I mean, I struggle to look at it from a local authority perspective because I'm not a local authority person, Andy. So, but in trying to think about how you have that longer term focus across an ICB and how you don't allow the short terms to crowd out the long term. I mean, there's a couple of things that I've focused on in South East London in particular. One is we have committed, and we've publicly committed, to protecting and growing a specified amount of funding for health inequalities and prevention each year for the next 5 years. I have no evidence base whatsoever for the number that we start off with. I have no evidence base whatsoever for the number we're going to end up with. But I think we all know enough to know we're not spending enough now and we need to spend more in the future. So if at least we get something visible and get a trajectory, then actually that's a start. And let's not overcomplicate it and make everything too difficult. I guess the other bit I think it's worth mentioning from an NHS perspective, Andy, is partly taking Carol's point about the sort of NHS upward-looking culture and what we're being asked to do all the time. What we try to create within the ICB is that the ICB feels as accountable to the Integrated Care Partnership as it does to NHS England. So the Integrated Care Partnership is much more concerned about getting longer term value and prevention than whatever they say Department of Health is. So we're trying to create a structure of accountability that means we respond to that ICP pressure as much as we respond to a Department of Health pressure.
Yeah. Alan, I see you've appeared on screen. Did you want to ask a question or provide an answer?
No, I just wanted to. I do think there is a sort of there's a nagging right, isn't there, really? And well, I certainly feel around our integrated care board that when you've got a local authority chief exec, or when you've got a director of public health who really understands the issue, and he's saying, "Hang on, what are you doing here? Why aren't you putting more money into prevention?" It's quite embarrassing, really, for us in the NHS. And so I do think there is that opportunity to learn. And we had a great example of Wolverhampton Council and their commitment to long-term funding of the voluntary sector. And I thought, wow, we really should be doing this. And so I think there's something in that. I think in a more formal sense, the health and wellbeing boards have a really important role in the next 3 months to review the 5-year joint forward plans. And so that is the formal framework where local authorities have a real opportunity to influence where we're going. And so, they need to maximise that opportunity.
Thanks, Alan. Carol, you wanted to come back?
Yep, thank you. And apologies for looking slightly distracted. I decided, because I wasn't feeling great, to work from home. And we have a young puppy who has taken exception to Richard's voice and is very jealous of it, and who's been causing mayhem, and he's just stolen a bag of black ink cartridges. So I now have an inky trail all the way across my kitchen. So that's why I was looking a little bit distracted. A couple of specific examples around the focus on prevention. One of the things we've done, this is part of the legacy from the Marmot work as well, is we've established in Manchester a Making Manchester Fairer board. And in some ways you could say that duplicates, but it links to Manchester Place board. But what it does do, with very strong leadership, with people with vested interest in tackling some of those health determinants and keeping that agenda on the table, is keep everyone's focus very much on it. One of the things we've done is we've taken Public Health Grant Reserve, topped it up with a few other bits of money, and created a specific funding stream to support investor save measures around what we call kickstarts that really start to tackle some of the health determinants. And I think that's really important because it helps us keep that balance and that focus on the longer term position. And likewise, having some of that legacy of the integrated working with adult social care is keeping that focus on the next stage of what we call BOBBLE, which is better outcomes, better lives, and that focus on strength-based and prevention in social care and how it reads across. We've done stuff around strength-based social care practice, but now very much on front door and how people access services and who signposts where, just to keep that, taking the experience of some of the integrated teams and others from their on the ground queries, approaches around health and social care to how we get that just ingrained into our practice at the moment. So, we don't have all the answers, but I think there's a couple of practical examples of what we've been doing.
Yeah, okay, thank you. Just prompted by a comment I made earlier on when Richard McCallum spoke about Scotland and their plans for a national care service. We've had a question in saying, is the end point of integration a single national health and social care service? Richard, thoughts on that?
Above my pay grade, Andy, I think. I think you could do a lot without that. I think we've got a lot of space to fill before you even need to get in to that. I think the constitutional difficulties around doing that, I find it really hard to work out how they're resolved. But yeah, there is so much space for us doing greater integration without any further legislative change. We're just not taking it yet, and we just need a bit more patience.
Yeah, I think, Carol, I think Andy Burnham, at least when he was Shadow Health Secretary, did talk about a national care service. And obviously he's in now Mayor of GM, and there was an announcement in the budget last week about further devolution to GM. I don't know, well, any thoughts on either of those two things? Firstly, the sort of national care service, integrated NHS and care service, or indeed the implications of the budget announcement for health and care in GM.
Thanks. Dealing with the kind of issue around national social care service first, and at risk of speaking above my pay grade, I totally understand, where some of Andy Burnham's frustrations came from, and the variations in practice quality and some of the real legacy issues in adult social care. But I'm a passionate believer that adult social care, in a lot of cases, is about people's lives and how we work with communities and how we work with practitioners and providers on the ground. So for me, there's always got to be that element of whatever your arrangements are, how do you build in that neighbourhood, locality, expertise and understanding of your population and the particular issues, as opposed to moving to a national one-size-fits-all. I think what we have found from a national one-size-fits-all with the NHS is you don't get that standardisation of approach necessarily anyway. And one of the things that also really kind of exercises me is social, in the same way that if you're talking about looked after children and corporate parent, it's the business of the whole council and partners, provision of decent support to enable people to be independent, live their best life and provide support where it's best needed. You can't just do with a residential care home or a home care service. It's how do you wrap around all of those functions in place, the leisure offer and every housing offer and everything else in the way that best supports residents. And I think that's incredibly difficult to do at a national level. In terms of the Trailblazer, I think one of the things that's been, it is completely separate from the health and social care arrangements in Greater Manchester without any kind of direct read across. But what we did do was, when we did the devolution MOU in 2016, we took a lot of learning from the devolution discussions into that. And like vice versa, we've taken some of the learning from the devolution discussions and how you manage, some of those key principles. Richard was talking about principles, subsidiarity. Trailblazer is around drawing functions into GM, not sucking them up from local authorities, but making decision making at the most appropriate level. How you manage things like different funding streams that emerge through spending review periods. A lot of that learning came from the health and social care discussions. So I think it's interesting synergies, but not necessarily directly related.
Okay, thanks, Carol. I noticed that, I mean, I think Terry, Richard, McCallum, Lee are still on the webinar. If anything you'd like to add to that bit of discussion, it's not compulsory, but you've got a chance to add if you wish. Just switch your camera on if you do want to come in. Alan, you got your hand up again. Do you want to come in again?
Yeah, I just a small point really. In the like Richard and Carol, I'm not necessarily going to comment on the national care option, but I do think there are some interesting opportunities that are arising, and the whole point really of this is for us to do things differently. So Northumbria have invested in creating a care organisation from the NHS. Now, I don't know how that operates, but I do think it's something we need to explore as integrated care boards. You know, if there is innovative practice going on, what can we learn and can we possibly replicate it? And back to the earlier point about assessing value for money, if that is a value for money approach to providing care in a place, then that is well worth us putting some investment into. Okay, thanks, Alan. Terry?
I completely agree with the earlier comments that a single one-size-fits-all national approach doesn't work, and we need to build on in terms of the local authority element, in terms of their understanding of their local place. But I think the previous speaker made a really important point that we need to be sharing the best practice, which is being applied and developed throughout the country, and find mechanisms to enable that best practice to be shared so that we can learn from each other across the country. There's no magic solution, but we need to be learning from each other. Thank you.
Okay, thanks, Terry. And Lee?
I agree with Richard. There's loads to go at before you get into a sort of national health and care service space. I think there's loads to go at. I do think, though, there's a bit more. How do you converge around a more plural set of indicators that you're going to start to measure ICBs with than some of the narrower sort of process targets in the sort of NHS side of the street? So I think there's something really important about how we're beginning to say something over time about getting into that upstream intervention place and doing something different. So it's good that you can set a local target around, for Richard's say, about what proportion of our spend is going to be in prevention. And I think over specifying it might be a bit of a waste of time. However, but if you come under a lot of pressure to go, well, that's fascinating, Richard, but as chair, we need you to be saying something really eloquent in the next 10 minutes about 4-hour waits. It pulls management focus in a slightly different direction, doesn't it?
Excellent. Yeah. Okay. Richard McCallum.
Yeah, I feel I better come in and make the case for the National Care Service, given the comments from others. But no, like others, it would also be above my pay grade. I think, I'm very conscious as well. We're still going through a leadership election at the moment as well in Scotland, so that's another factor. But in terms of the Scottish Minister's policy around the National Care Service, I mean, I think some of the points have been made, but I think that variation, and particularly that unwarranted variation, is something that has frustrated ministers. And we've had a system of integrated authorities, as I said earlier, in place from 2014, and I think that there is a concern in terms of that unwarranted variation that is across the system. That's not to say, just to pick up on the earlier point from Terry, that there won't be local variation. Of course, there has to be, because we've got very different systems operating across Scotland. But I think it probably reflects that unwarranted variation. I think there's a lot to go at, and I think even before we get there, and it might take time to get there, the points that have been made about the improvements that can be seen in the current structures that we have, I think there's huge opportunity, and certainly I know that will be the case in England as well. Cheers, Andrew.
Okay, thanks, Richard. I think we've already covered all the questions in the Q&A. I don't know, Ellie, was there anything you wanted to say or ask finally?
No, I think all my questions have been answered. I'd just like to thank all of our panelists. It's great to hear that they are all buying into our principles-based approach. as set out in the publication. I think for me, the key theme that's come out again today is the real need for that shared understanding between the partners, and as Terry quite right on point as usual highlighted, the need to share learning across the entire system. And I would encourage the audience, if they haven't already done so, to take a look at the publication, because that is exactly what SITFA are trying to achieve in this space. And just a final word from me to say, if this is something that you do have an interest in, or you need further information on, then please do have a look at resources online, and feel free to get in touch if there's anything that occurs after today's session.
Okay, thanks, Ellie. So in that case, then I will draw things to a close. Firstly, thank to all the delegates for taking time out of your busy schedules to join us on this afternoon's webinar. As I explained at the start, the slides will be sent out to delegates after the event. It's also been recorded and will be published on SITFA's YouTube channel. Any feedback about the content will be much appreciated. Any thoughts about future events and future coverage would be also very much appreciated. Can I thank all the panelists for their fantastic insights and contributions, and for the really rich discussion that we've had. It will go a long way to get a better panel talking about integrated care than we've managed to establish this afternoon. So thanks very much, and I'll thank on behalf of all the delegates who can't clap for you for that. And then finally, just these things only work because there's people behind the scenes making sure that the thing is set up, the thing is established, and the thing works on the day. So the team at SITFA, which include Monica and Louise and Fiona, thanks for all they've done behind the scenes to make sure this event has worked as well as it has. So I think we've got a few minutes back for your diary. So enjoy the rest of your afternoon if you've got other things to do. Apologies if you've got more work to do, but if this is the last thing you've got in the afternoon, enjoy the rest of your evening. Thanks ever so much for all of your contributions, and hope to see some of you again soon. Thanks very much. I'll stop recording, and Ellie, do you want to hang on at the end? And anybody who can hang on at the end, if they want to